We're
Okay,
excited
great.
to have David Fetzer from UT Southwestern to talk to us about contrast-enhanced ultrasound. Take it away.
Yeah, thanks everybody. As my colleagues lovingly call me a ultrasound zealot, they asked if I could give a few cool cases on contrast-enhanced ultrasound, and then for those of you who may not know as much about contrast-enhanced ultrasound, I have a few introductory slides as well. I was talking to Gaurav, and he said I was being super lazy during this whole COVID crisis, and that he needed me to actually do something academic. So I volunteered to give a short little lecture here. So, so as far as a brief introduction, you know, I talked to a lot of colleagues at other institutions, and less so now than a couple of years ago, but there were a lot of excuses why contrast and ultrasound wasn't being performed. And really none of these should apply anymore. It's not research, it's not dangerous. It's done worldwide, and it's being done more and more across the United States. So I really want to dispel the myth by bursting all these bubbles and getting you guys all interested in at least considering contrast-enhanced ultrasound, at least if you're not starting, if you have started, all the crazy uses we can think about for this cool modality. Just as a review, there are 3 FDA-approved agents in the United States for cardiac use. The one you're going to hear most about is Lumason. That's what it's called in the United States. In published literature across the rest of the world, it's called Sonoview. But there are plenty of institutions using Definity as well. I recommend just using whatever your cardiology lab is using for their bubble studies, because that's really how these agents got started or got disseminated in clinical use. So we can started with Definity, and then we've moved over to Lumason just because it's easier to store and mix and administer. And keep in mind, there are now CPT-1 billing codes for contrast-enhanced ultrasound that actually, if you do, say, a pre-contrast ultrasound and then you inject contrast for a renal lesion or liver lesion, the RVUs for that are more than a contrast-enhanced MRI of the abdomen and pelvis. So if you're worried about, you know, the time it takes to get out of the reading room and perform these studies, keep in mind that the CMS has actually looked at that and said, you know what, we really need to reimburse the radiologists for that time it takes. So the RVUs are actually pretty good. So what are these agents? So as opposed to gadolinium-based agents and iodinated-based agents, which are small molecules, these are actually small particles. These are microbubbles about the size of red blood cells, about 3 to 5 microns. And they consist of a gas core, in this case, sulfohexafluoride, encased by a lipid or a protein shell, in this case, phospholipids, and this is the molecular makeup of sulfohexafluoride or Sonoview or Lumason. The phospholipids or the or the protein shell is biocompatible, and so the body doesn't even know it's floating around in the body, and the gas diffuses across the alveolar space into the airways, and you breathe it out. Another interesting aspect about these agents is that since they're the size of red blood cells, they are considered a pure blood pool agent. So unlike iodinated agents and gadolinium-based agents that, of course, have this extravascular interstitial phase, bubbles stay in the blood pool. They do not leak out at all. So if you see bubbles in your image, there is blood flow. If you're looking for blood flow and you don't see bubbles, then there isn't. So it's really great black or white, on or off kind of test that we can perform. And as I will show you later, it gives us some advantages when we're doing perfusion analysis. What's nice is since these bubbles are cleared by the lungs, the half-life is about 5 to 10 minutes. So you can actually re-inject every 10 minutes. And there's really no maximum absolute dose limit. So I've given 2.5 vials worth of contrast in one setting during a complex liver biopsy, because every few minutes I would re-inject, re-identify my target, re-biopsy, and then the bubbles would wash out and I'd give another dose. So for exams where you want to do multiple arterial phases or interrogate multiple lesions, or for procedures, this is a huge benefit. The other great thing is that these bubbles are, that ultrasound is exquisitely sensitive to microbubbles. So here you're seeing just tiny little individual bubbles in a micropipette using a clinical scanner. So these are the size of red blood cells, but they're giving off so much signal that we can actually see them not just in vitro, but also in vivo. So this is a renal transplant. Between injections, you can see individual microbubbles in the parenchyma of this transplant kidney. So this allows us to administer tiny doses of contrast, unlike in CT or MRI. Another unique property of bubbles is that they actually oscillate with the pressure wave of the ultrasound pulse. So unlike soft tissues that oscillate linearly, meaning they compress and rarefact to the same degree as the ultrasound pulse, bubbles actually contract and rarefact exponentially. And so this nonlinear response creates really strong harmonics. And we can take advantage of that. This graph here is showing representative harmonics of the primary frequency. And if we use a technique called phase inversion and send in 2 pulses of opposite phase, this nullifies signals returning from along the primary frequency, but relatively amplifies the signal from the microbubbles. And this allows us to basically do real-time tissue subtraction. So this is a image side by side of grayscale and contrast mode. And my videos aren't working. Are you seeing my videos playing?
No.
All right, let me try something here. Apologize.
Yeah, because I assume some of your other cases are going to be videos, right?
Oh, they're all videos. Let me just pull it up in this format here. It's not going to be as pretty, obviously. Okay. Can you see that playing?
Yes.
Yeah.
Okay, so I'll just play it like this. I apologize. Hopefully that's not too distracting. But you can see here, this is post-ablation, and the ablation cavity has no bubbles in it other than the macro bubbles from the RFA. It's showing that there's complete ablation of this prior HCC, and then there's rapid washout of these lesions that turn out to be lymphoma infiltrating this liver, which you can't see on the grayscale image. A little bit about nephrotoxicity, or safety profile. Of course, there's no nephrotoxicity since these are cleared by the lungs, so you can give it any level of renal dysfunction. There's very, very few adverse reactions. The reaction rate is less than that of CT and MRI agents, and really there's no contraindications to speak of. We've even given it in pregnancy, we've given it in the ICU, in the OR. It's a really versatile contrast agent. There's a couple FDA-approved agents, but of course, what I'm mostly going to talk about today is the off-label uses. That really shouldn't scare anybody, because as we know, we give off-label contrast agents in CT, MRI, and fluoro all the time. So we really shouldn't be worried.
David, quick question.
Yep.
There used to be a black box warning or something about it, right? Like that there was.
Yeah, so during the initial trials, of course, these agents were being FDA approved for cardiac use, and cardiologists were administering it to do bubble studies, oftentimes in patients that were dying of cardiac failure. And so they had a few deaths, and because they were on trial, those deaths got attributed to the bubbles, even though patients were being studied because they were in heart failure. So the thought was that if patients had right to left shunts, these bubbles would get into the arterial circulation, or big bubbles would get into the arterial circulation and cause MI and stroke. But current agents are so well formulated, and the number of bubbles that large bubbles that may go from left to right are so small that those black box warnings have been lifted. So I don't hesitate. If the patient's talking to me and breathing, I give it. I no longer worry, and that's pretty consistent among all of the users in the Western Hemisphere. So a few common uses. Just as a reminder, there's now 4 components of LIRADs. We all know and love CT and MRI LIRADs, and now treatment response LIRADs, but there's ultrasound LIRADs for screening and surveillance, and CEUS LIRADs as well. So this is a screenshot of a typical case for screening and surveillance LIRADs, where we see an isoechoic rounded observation in a patient at risk. It's a US3 positive case. And now the recommendation is this goes on to a multi-phase contrast enhanced CT, MRI, or ultrasound. What's nice for those of you that do your HCC screening by ultrasound, if you catch these in your lab, you can immediately place an IV, take the patient to bring the patient back to the room and do contrast-enhanced ultrasound. And there's an algorithm just like for CT/MRI that gets you to LR5. So here we are, the lesion with arterial phase hyperenhancement and washout, and this is LR5. Of course, you still need the CT/MRI for complete staging. However, this gets the patient a quicker diagnosis, and our hepatologists really like this workflow because they have their answer right away and they can expedite that patient's treatment and workup.
Is the timing of the washout the same as for CT and MRI?
No, it's a little different, and I won't go into the details, but for contrast-enhanced ultrasound washout, the timing and degree are both important. So we watch for the washout and its first appearance. It was really important whether or not it occurs less than 60 seconds, more than 60 seconds, or more than 2 minutes. And the degree of washout, it should be this mild washout. If you have punched out washout like a black hole, less than 2 minutes, then that's too fast a washout, and then that is a contrast-enhanced ultrasound feature that gets that observation to an LRM, because that rapid washout can be seen with cholangiocarcinoma. As opposed to this focal liver lesion, another high-risk patient, hep C, HIV, echogenic nodule. In a normal patient, we call this a hemangioma, but an at-risk patient, we have to kind of hesitate. But of course, with contrast-enhanced ultrasound, you see the classic peripheral discontinuous nodular puddling and the slow centripetal fill-in, follows the vascular pool, classic hemangioma, no further workup. If we saw this on CT/MRI, we'd be done. And then similarly with contrast-enhanced ultrasound, we're done. Here's that rapid washout I was talking about, pretty classic for metastasis and cholangiocarcinoma within really 30 to 60 seconds. Otherwise, occult metastases turn into these black holes, making them very easy to see and target for biopsy. Liver abscesses are actually really pretty. We're used to seeing them here on CT, with the flower petal sign. But it looks very similar here, this multiloculated abscess on contrast-enhanced ultrasound. Of course, our biggest volume actually comes from kidneys. So you have this echogenic mass in the lower pole of the left kidney with abnormal vascular flow. Obviously, this is going to be renal neoplasm, but it's really pretty to go to contrast-enhanced ultrasound and see this light up like a light bulb. You can see it's partly endophytic, shows solid arterial phase hyperenhancement. It does wash out, and this turned out to be a clear cell renal cell carcinoma, enhancing just like you expected on CT or MRI.
David, for that one, how would you differentiate it from an AML?
So AMLs actually enhance much less than RCCs. So they show kind of a low-level enhancement. They're actually harder to differentiate from papillary renal cell as opposed to clear cell renal cell.
Okay.
So for procedure guidance, it's very useful for all kinds of different things. I'm not going to focus on that today. But this was a patient with lung cancer. This was a new mass. We said this is metastasis. They're like, oh, it may not be. It may be a second primary. It may be abscess. You know how oncologists are. We need a tissue diagnosis definitively. Problem is that obviously there's a lot of suspected necrosis. So with the resident, I said, hey, go ahead and give contrast. And what you'll see is that there are large areas of non-enhancement, that then it's much easier to see the peripheral jagged areas of persistent enhancement, so you can target some of these areas and ensure that your diagnostic sample or your sample is going to be diagnostic. So for large necrotic masses, we've been using this to identify the viable components to biopsy. All right, and then this is really the icing on the cake, the kind of fun things I've been doing recently with contrast-enhanced ultrasound. So we've been in our department thinking, what kind of big questions can we answer with ultrasound contrast? So for instance, is something solid or not? Back in 2018, this patient presented to the ER after trauma, and this was diagnosed as, with abdominal pain after abdominal surgery. and this was diagnosed as a postoperative hematoma. Well, the patient presented a year later, and that, quote, hematoma had increased in size. You can see here this horseshoe kidney with evidence of probably chronic kidney disease, and so they didn't want to give iodinated contrast. And so we said, well, we could try contrast-enhanced ultrasound. And I bet this is not going to play, so I'll have to come back out. And here you can see, even though because of the shadowing from the umbilicus, you can still see that this mass shows solid enhancement. And so we ended up biopsying this under ultrasound, and it came back as a spindle cell tumor, which was pretty cool. This was another really interesting case. This little nodule had been seen by CT. It was palpable to the patient, had been biopsied unsuccessfully on the outside, with results being insufficient for diagnosis. So we came back and took a look at it, and you can see here, this is the nodule here right over the top of the SCM, just deep to skin with internal vascular flow. We put a needle in it, and all we were getting back was blood. So I was like, well, you know what? We have a needle in it. Let's put bubbles into the lesion. So you'll see on this clip here, my needle in the lesion and a little puff of contrast. Has some shadowing. So what's interesting is that since these bubbles are so big, they're not going to intravasate. So it's not like doing an HSG and you give too much contrast under pressure and then you see the veins fill. The bubbles are only going to fill a space or fill a lesion like this if it's a space, if it's something where those bubbles that are big can actually diffuse into. And then if you, after we injected into the lesion, we actually went off to the side and looked at the jugular vein and the carotid artery and saw the bubbles circulating in the patient's circulation. So can anyone guess what this was?
Some kind of like varix or like something communicating with the actual internal jugular vein.
Yeah, it was a soft tissue hemangioma. So because the hemangioma is a big sac of abnormal vessels, if you inject something into that, it eventually gets into the circulation. So this is actually the second soft tissue hemangioma I've diagnosed with contrast-enhanced ultrasound by doing this. So if anyone has a third, I'd have a case series and we can write this up. So let me know if anyone else has one that we can diagnose with contrast-enhanced ultrasound.
So David, you're saying that if you had injected it, say it was like a necrotic lymph node, and you had injected it, it would not have ended up in the vasculature because it did not.
Correct.
It cannot travel from a tumor into a vessel, only from a vessel to a vessel.
Yeah, I mean, there's some debate about, if you core biopsy something, obviously you've disrupted some of the vascular spaces and disrupted some capillary beds. And if you then inject contrast, do some of those bubbles get into the circulation? Well, maybe, but probably not a lot of them. So usually I think if you try to inject bubbles into a solid lesion or a necrotic lesion, they're just going to either pool right there at the tip of the needle where it dissects out from the needle tip, or fill the necrotic space without getting into the actual vascular space.
Cool.
We've been doing it for gallbladders. So differentiating polyps from adherent stones from inspissated bile. So it makes these really pretty pictures of these little, these cute little polyps on these little stalks, just like you'd expect on a photograph from pathology. Unlike this next case, which comes from one of my colleagues, this is an old lady, I think, a 74-year-old male. In 2008, was diagnosed with inspissated bile. But in 2019, last year, came back to our ER with abdominal pain, and this is what the gallbladder looked like with some vascular flow. So obviously this raised the suspicion for malignancy. And my colleague did a beautiful contrast study out of the ER showing really irregular arterial phase hyperenhancement in the body and the fundus of the gallbladder with rapid washout, and this was indeed gallbladder adenocarcinoma. So differentiating sludge or inspissated bile tumefactive sludge from malignancy has been a fun indication for us. This was a patient with HIV, Hep C, came in, decompensated, and found this in their liver. So in the hospital, they wanted to know if they needed to biopsy it. although by CT, we thought it looked like an abscess. So we thought, well, do we need to drain it? So a patient came in on my service and we gave contrast, and of course it's a big black hole. So it's a non-vascular cavity, most consistent with abscess. So of course we said, okay, well, we'll drain it. So we put our needle in, got some purulent material out, and then I, for fun, put in some contrast and showed the cavity filling. So essentially an abscessogram. And this can be used if you're hoping to see if multiple locules communicate. If you need to put in, say, one catheter or multiple catheters, that's been fun. Or to make sure that your catheter is still patent and within the abscess cavity. So instead of doing this under fluoro or CT, contrast ultrasound is another possibility. What was really fun is after we injected the contrast, but before we put in the catheter, we noticed these little linear areas of high signal. Anyone know what those are? Going off my teaching point from earlier about the hemangioma. So these aren't vessels.
Hmm? Well, yeah, I was thinking they were veins, but I fell for your.
Yeah, not vessels, because the parenchyma is not enhancing. But what goes along with the vessels?
Bile ducts.
Bile ducts, yeah. So this is a cholangitic abscess because I injected the contrast into the abscess cavity and then the bile ducts filled up. I kind of showed this case already. This is a post-ablation cavity after microwave ablation, I think. And the interventionalist was really worried about bagging the gallbladder wall, which is here with gallstones. And so not only did we do this contrast ultrasound to verify that the ablation cavity was encompassed the prior HCC, but that the gallbladder wall enhancement was maintained. This is another ablation case, so fairly easily seen on grayscale. Here's the washout, and after the ablation, we did another run of contrast ultrasound and showed there was still some nodular enhancement in the ablation cavity, which allowed them to, or on the edge of the ablation cavity, which allowed them to redirect their ablation needles and re-ablate. So instead of having to wait, 3 months or so to do a follow-up CT MRI, multiple papers have shown that utilizing contrast ultrasound during your ablations allows you to improve your placement of your needles and ensure complete ablation of your target without the need for re-ablation 3 months later. So I think that literature is supporting that as a really strong indication. Other cool indications. So this was a LRM lesion in this patient at risk, kind of almost rim enhancement with maybe some capsular retraction. So came to ultrasound for biopsy, and you can see kind of this, what we thought was somewhat subcapsular lesion with arterial phase hyperenhancement. One of my colleagues, I have no idea what that is. One of my colleagues biopsied it and then gave contrast afterwards. And unfortunately, I don't know why these videos aren't, oh, it's because I'm still in this mode, I'm sorry. Here's the lesion, and then within a few seconds, start to see another finding. Anyone know what this is? So this is the biopsy, guide tract. So you can see this little linear focus here, and then all this signal building up along the capsule.
Yeah, Justin is saying extravasation.
Yep. So active extravasation. So we've now seen this twice with livers and twice with kidneys. A couple of these patients went to angio to confirm active extravasation. Others were treated conservatively. But again, you're only going to see bubbles fill the fluid around an organ if there's active extravasation. It's really great on-off. So our nephrologists at our institution do the random native kidney biopsies and liver transplant or kidney transplant biopsies. So several times they've run into the reading room saying, oh my God, I think there's a bleeding. And I immediately go grab a box of Lumason, take it into the room, mix it up, inject it. And then we're able to see, there's always a hematoma, but then we're able to see if there's actually active extravasation without sitting there for 15 minutes trying to see find a little Doppler flash in the biopsy tract. We can actually just show the active extravasation or lack thereof and then call VIR and say, hey, this patient needs an angio. So that's been fun as well. With portal vein thrombus. We've been asking, is it malignant or benign? This patient had a prior history of diverticulitis. And so here you can see absolutely no signal in this portal vein, arteries on both sides. And you can see that it's all bland thrombus, and this turned out to be thrombophlebitis from incompletely treated diverticulitis. So we've also been using this in patients where there's suspicious for TIV, and we've shown it to be a malignant tumor in vein. Endograft leaks. This is something that I tried to start here, but then our vascular surgeons kind of took it over once they said it would I showed them it was a viable tool. These images are a little grainy because this was an obese patient immediately post-op, but this is a long orientation. You see this puddling of contrast on the cranial margin of the aneurysm sac. Here, and this is a grayscale contrast overlay available on some systems. So we called this a type 1A versus maybe a 3. And then on the anterior wall of the aneurysm sac, we saw another area of contrast puddling. So we thought that that was type 2 from the IMA. And then finally, this is a trans view. So this is aorta. This is the graft here. This is the excluded aneurysm sac. A little area of puddling along the right lateral margin. So that was another type 2 from a lumbar. And the vascular surgeons, of course, said, there's no way you have 3 endo leaks in one case. They didn't believe me at all. So they went for a CTA, and sure enough, there's the type 1A, there's the type 2 from IMA, and there's the type 2 from lumbar. So we showed perfect correlation, one-to-one correlation between the two modalities. So that was pretty fun. This is one of our first cases, actually. This is a 79-year-old male coming in with abdominal pain, lethargy, and remote history of prostate cancer. And so abdominal ultrasound was ordered out of the ER, and we see here on this trans view the aorta, SMA, and then where the IVC is supposed to be is this echogenic mass. And they showed some flow here, but the concern was, okay, is this intrinsic or extrinsic to the IVC? And non-contrast CT, of course, was non-helpful. And so we did contrast-enhanced ultrasound. And so here you have the spine, the aorta, IVC is compressed, though patent, widely patent, and you have this enhancing mass posterior to it, which was confirmed to be metastatic prostate cancer, lymphadenopathy from prostate cancer. But what is really neat in these cases is that you can essentially do an ultrasound arteriogram and venogram. So I'm going to walk down the whole abdomen from top of the liver down. So here you're seeing IVC in the hepatic veins. This is the right portal vein, and as we go down, you'll see IVC, portal bifurcation there. Here's the aorta. Here's the celiac with hepatic coming across, and splenic. There's the hepatic artery with the bifurcation right and left. Here's main portal vein, IVC. Walking down the abdomen, here we have SMA, splenic vein, portal confluence, IVC, renal veins, and further down, here's the compressed IVC with the retroperitoneal lymphadenopathy. So this is, again, one of our first cases and really got us thinking about all the different ways we can use contrast-enhanced ultrasound for vascular imaging, really point of care out of the ER and the ICU, when other modalities may not be as portable or contrast agents may be contraindicated for whatever reason. This was a renal transplant Doppler. Again, the transplant surgeons are still wary about giving contrast and CT MRI for various reasons. So there was a little bit of delayed upstroke in this allograft that was producing poor urine. Elevated velocities at the anastomosis, and so there was a concern for renal artery stenosis, but they wanted another study before they went to angio, and I'm glad they did, because here's the contrast-enhanced ultrasound showing the anastomosis to be widely patent, and these studies are really pretty because you can see the vessel all the way across without any kinking or stenosis. And actually, we've been doing a lot of perfusion imaging, showing the renal veins, the arteries, all to be patent. This is from a publication we did showing the renal vein and the renal arteries. And you can do these beautiful perfusion studies with these microbubble agents. This is kind of a time-resolved MIP, if you will, showing the bubbles build up through the cortex, no perfusion defects. Again, this is that overlay of contrast with grayscale. And then this is just a sweep through the kidney showing kind of homogeneous renal perfusion. And you ask, well, why is that important? Well, we've actually had several cases where we've had cortical necrosis or segmental infarctions in these kidneys. So again, it's on-off. If there's no blood flow, it's not going to get bubbles. If there's no bubbles, there's no blood flow. So it's a really fun tool in that regard. And then we've been doing some perfusion analysis. So this was an indeterminate renal lesion projecting off the lower pole. And you can see here this very mild low-level enhancement. Enhancement was not seen by multi-phase CT. The HU increase was only about 12 between pre and post contrast. So it was diagnosed as a likely complicated cyst. But you clearly can see bubbles in this lesion, and we put ROIs on here and showed expected perfusion curve relative to the kidney, and this turned out to be a papillary renal cell carcinoma, as expected.
David,
And
this has been amazing. I just want to leave time for cases. So
yeah, this is my last case.
Okay.
And this was a young lady who, I don't know if you've ever heard of this. She had hyperparathyroidism, and they took one of her parathyroids at parathyroidectomy and put it in her forearm. And we all know that that occurs. But what happened is they macerate the parathyroid and put it into the forearm. They're supposed to put it in a little muscle pocket. Well, this general surgeon just put it underneath the skin right on top of the muscle. And so these little foci basically started to disseminate throughout her forearm. She'd already had multiple surgeries to remove these. She had lost her brachioradialis, and she had tons of scar, and she still had hyperparathyroidism. So this is something they call hyperparathyroidism. It can also happen in the neck. If they spill a parathyroid during surgery in the neck, you can get multiple foci of hyperactive parathyroid tissue throughout the neck. And they really wanted these to be treated, but not surgically because of all the scar. So I could find a couple of them, but I wanted to make sure that I could find multiple of them for ethanol ablation, so that I treat half of them and leave half of them alone. I could find 2 of them with grayscale ultrasound and Doppler, and with contrast enhanced ultrasound, these lit up like gangbusters. And with contrast, I was able to show that there were multiple, at least 5 or 6 foci. So I went ahead and treated the largest 2 foci, and her PTH came back to normal levels, and she's doing well. So
that was awesome. I have a couple of quick questions.
Yeah.
One is, it sounds like sometimes you do it like on the spot, like, okay, I'm going to go do this. Do you need to get like certification, or does insurance just cover this? Is this a relatively inexpensive agent?
Well, given bulk pricing, the agent is not very cost effective right now. But of course, when any new agent comes out that's not being purchased in large quantities, it's usually relatively expensive. I mean, Ablavar was the same way. Eavist at one time was the same way. So I expect the price of microbubble agents to go down. I haven't had any pushback. At our institutions, we have an order entry question on all of our ultrasound studies that basically ask the ordering provider, can we add contrast if the radiologist deems it necessary? And this applies, of course, to CT, MRI, and now ultrasound. So we added that order entry question to all of our ultrasound studies. So it essentially allows us then to reflexively add ultrasound contrast on any of these studies prospectively.
Cool. That was amazing and inspiring. Thank you.
Thanks.